going and going. And what's at the end of the muscle? What's at the end of this line of signaling? It's a muscle. So we have the muscles just going and going and going. So we have the convulsions that are associated with an out of control generalized seizure. We'll get to that in a moment. But again, you see how useful it is just to come back to your basic model. Now, a seizure can have many causes, and it can be general over the entire brain, or it can be partial, just in a certain area of the brain. And we'll get to those differences in a moment. And again, that's what the slide is saying. It can be generalized or focal, and another term for focal is partial. And we'll talk about those as we get into these next slides. Now, a convulsion is a specific type of muscle activity that is caused by alternating tonic-clonic, where the body is going back and forth, contraction, relaxation, contract, only very fast, and it's obviously not well controlled. And the reason it's not controlled is the brain is just sending these continuous nonsense signals. Now, anybody can have a seizure. That does not mean that you have epilepsy. Epilepsy is a disease of seizures, a disease of chronic seizures, where the patient has seizures either for a known reason or an unknown reason over and over again. Okay? Now, what are some of the things that might cause a seizure disorder, might trigger it? Well, if you had a lesion on your brain somewhere, that would mean that the capacity of the brain to control itself would be limited. If there's a biochemical disorder such as alcohol, excess alcohol, or withdrawal of alcohol, or another very neural active substance like cocaine, for example, or methamphetamine, or many medications that were given. If those are pulled away precipitously, you could have a change in your biochemistry, and it would be difficult for the nerves to maintain homeostasis, and they would just start firing at random. Trauma to the cerebral area where the brain is just injured, or epilepsy itself. Now, what are the types? This is really important. What are the types of seizures? Well, there's two general types. Before you get into all these details, I want you to look at the two main types: partial and generalized. Okay? If you get that, you're going to get the rest of this. Okay, now partial means it begins locally or focally. Remember, we said that a partial seizure is just in one part of the brain. Now, there's three types of partials. There's simple partial, there's complex partial, and there's secondary generalized. And we'll talk about each of those in a moment. But then you also have the generalized seizure. Now, the key to that is it's overall. And it's both hemispheres. It's bilaterally. The effects are symmetric. And it does not start in some one place and spread as far as the patient is aware. Okay, and there's several, and one very important aspect of this is usually the patient loses consciousness during this because there's just too much electrical activity in the brain to retain high quality alert and oriented consciousness. Now, there's several different types of this. One is absence, and this means, and a lot of times this affects younger people, and it's a situation where the person is kind of zoning out, they're kind of daydreaming, or they're kind of, for lack of, absent, we might say. That's the kind of situation that you have with the absence, and oftentimes the children. And you might have a child that's staring out the window, or a teacher thinks they're daydreaming. And it's mistaken for being just kind of lazy. Myoclonic or tonic-clonic, these are situations where the muscles are involved. And you see, anytime you see that word myo, it means muscle. So you see the muscles acting erratically. Or atonic, which means that there is no muscle tone. We have something called a drop attack, where the patient just loses their muscle tone, just collapses. Excuse me. Now, epilepsy, this is the disease of recurrent seizures. Now, this is caused by this is what we call multifactorial, because you have both genetic mutations and as well as environment. So you have the environment coming together with the patient that is susceptible. And it can be caused by the actual wiring, the actual structure of the way the neurons are organized or disorganized. It can be caused by a perpetual imbalance in the neurotransmitters. And it can also be caused after an injury. An injury can actually provoke onset of repeat seizures. But what are the factors in epilepsy? Well, the thing is, the neurons are hypersensitive. They are very easy to respond. It doesn't take much to trigger them. And very importantly, ladies and gentlemen, we say the signal propagates. So this signal goes from one to the other, to the other, to the other. And in reality, ladies and gentlemen, you just don't have two nerves connected to one another. You have millions of nerves. So you may have 20, 30 nerve terminals coming into this axon, or coming into this nerve, and this nerve might connect with, let's say it wasn't connecting with a muscle, but it was connecting with 20, 30, 40 other neurons, and so the signal just gets propagated, and it perpetuates itself, and it spreads throughout the entire brain, and it gives you that generalized seizure. Okay, now, what are the manifestations? What are you going to see in the seizure? Well, there's several phases. One is called an aura. Now, not every seizure has an aura. If a patient has a generalized seizure disorder, this is where their entire brain seizes, they may or may not have an aura. If they do have an aura, that is what we call a partial, because the aura is actually considered part of the seizure. So you have a generalized plus an aura, and together they make what's called a partial generalized. Hopefully a lot of this terminology doesn't throw you off too much. But notice that an aura is considered a seizure in and of itself, and it immediately precedes a generalized seizure. Now remember, in a partial, you are still conscious. So this is why patients will remember their aura. Their aura might be, and it's usually a change in sensation. Either they start hearing noises, or seeing bright lights, or smelling certain odors, and that's actually a seizure in and of itself. It's a partial. But if it continues to a general, then we call that a partial generalized, and the partial part is called an aura. The prodrome. The prodrome is something that actually occurs before the seizure, and it's actually not part of the seizure, whereas an aura is part. Now, the prodrome is actually kind of, you might look at that as kind of a little warning signal that maybe I'm starting to get into that seizure mode. I'm not there yet, but it's kind of a little warning sign. The postictal side is afterwards, and this is when the signs of the seizure have ended, but the patient is still very much in the postictal phase. And one of the characteristics of there's a lot of them, but one of them is they're very fatigued. They're very tired, because this is, ladies and gentlemen, you can imagine that seizure going off and lasting a few minutes. That is very exhausting. There's so much activity, and that seizure will burn up a lot of glucose, and it's very exhausting. And of course, it's very scary too. So there's a lot of emotional investment in it, and so the postictal phase is oftentimes characterized by tiredness or sleepiness. Now, here's a learning check. A patient is admitted for routine hernia repair. The patient has a history of seizure and states, "I think I'm about to have a seizure." Now, how does the patient know he's going to have a seizure? And what behaviors might the patient experience after that? Okay, well, how do they know? Well, it could be a prodromal warning, or it could even be kind of a slow aura process going on. Either of those might explain that feeling that they have. And then also after the seizure, they're going to be in that postictal phase of being kind of tired, and the brain is resetting, starting to reset itself at that point. Okay, now you have what's called acute confusion, that's or ACS, and there's some causes of this, and this is where the patient is normally conscious, but they become acutely, that is immediately, without much chronic history or any chronic history, they become acutely confused. Now, what can cause that? It's a dysfunction of the brains caused by a drug intoxication or a metabolic disorder. The metabolic disorder could be a imbalance of glucose or an imbalance of a neurotransmitter, a disease of the nervous system, trauma, or surgery. Any of those could cause a patient to become acutely confused. And notice again, the pathophysiology of this is disruption of that reticular activating system. That's really one of the key causes of the alteration in alertness and orientation. Okay, again, delirium it usually ramps up over a little bit of time. You can read up on this, but this is a state of acute severe confusion, as opposed to a state of chronic confusion like Alzheimer's disease, for example. This is a transitory state, and it has a number of causes like surgery, withdrawal from central nervous system depressants, alcohol, narcotics, etc. could cause that. Okay, the next one, ladies and gentlemen, is dementia. And what is lost in dementia is probably the biggest one is memory. That's the one that we always associate with it, although the other factors play into it. And memory supports your orientation, supports your judgment. And so as that memory fades, you have less frame of reference, and you can start making bad decisions. The pathophysiology of this is the neurons can degenerate, as they might, for example, in Huntington's disease. We'll talk about that in a moment. Then it can also be caused by compression. You might have that if you get a swelling of the brain. Atherosclerosis, which would be a buildup of plaque in an artery in the brain, and that would cut off your blood supply. And again, trauma, of course, could play into that. Direct damage of the neurons. Okay, Alzheimer's disease is a form of dementia. We don't exactly know everything about it. It seems like every few months I read about a great discovery, and this is going to be the breakthrough, but we never just seem to break through. Now, I will say this, that we're now starting to recognize that Alzheimer's is multiple diseases. Or said another way, there are multiple diseases that have Alzheimer's-like symptoms. That is, with the plaque, the tangles, and some of them are early onset, late onset. Some have a very strong family component. Some don't. Some are more devastating than others. But I think in time, as we continue to research into the 21st century, by the end of this century, we're going to obviously know a lot more about these diseases. Now, very importantly, one of the known pathophysiology pathway is defects on chromosome 19 and 21, and accumulation of abnormal myeloid proteins and APOE molecules, and these lead to the buildup of plaques and tangles. That's really kind of the bottom line. And these are two buildups that can really disrupt the performance of the neuron. And you'll notice that the defects tend to be concentrated in the cortex and in the hippocampus. The cortex, of course, is the locus of thinking, and the hippocampus is very important for memory. So you can see how devastating this disease really is. And what are you going to see? Clinical manifestations in the clinic. You're going to see for that forgetfulness and memory loss. That's going to be, and of course everything else, the confusion and disorientation. But how do we evaluate Alzheimer's disease? Well, they used to say on autopsy. Of course, most people don't have an autopsy. So the way we do it, the best way is to rule out other causes. So if a patient is acutely or chronically mentally ill, you need to evaluate that to find out if that has a psychological cause or it has a medical cause. And the medical cause, again, all of those causes, it might be due to trauma, might be due to a change in chemistry, etc. So what you do is you rule out all of those factors, and if the only thing that's left is Alzheimer's disease, then you have a higher probability that's what it is. Okay, the central hemodynamics. Hemodynamics is just a fancy word for blood movement. So this is discussing the blood movement about the cerebral part of the brain. We have CBF, CPP, CBV. I'm not sure how important that is, but just to kind of give you some ideas of the blood flow and how important that is. And anybody that's spent any amount of time working with consciousness will tell you that getting this right, getting the right amount of blood, not too much, not too little, with the right amount of oxygen, avoiding the swelling, avoiding the seizure activity, that's all just critical to maintaining the consciousness of the patient and literally maintaining the personality of the patient. Okay, now the next topic is increased intracranial pressure, and this is increased pressure inside the brain. Now, what could cause that? Well, a tumor, a very obvious one, swelling, too much cerebral spinal fluid, and a hemorrhage inside the brain could all cause that. Now, very importantly for you to know is that of all of the components of the brain, the cerebral spinal fluid, the blood, the interstitial fluid, and the tissue itself, the one that's easiest to move is the CSF, or cerebral spinal fluid. So, and that gives us a little buffer. If there's a very mild swelling on the brain, we can shift the CSF and accommodate a little bit of brain swelling. Very important to know. And also there's this term autoregulation. And this is where the brain itself, because it's such an important organ, will be able to make local decisions about how to change the diameter of a blood vessel in order to get more or less blood to a particular side of the brain. Very important concept, autoregulation. Cerebral edema, this is swelling or fluid in the brain. And you have vasogenic, which is caused by a rupture or a leakage out of a capillary. So you just have blood literally leaking into the brain. Cytotoxic, which would be a metabolic factor, and interstitial, which would be a change in the quality of the interstitial fluid. All of those types of things can affect the risk for swelling. Huntington's disease, a very devastating disease. It's also known as Huntington's chorea. It is autosomal dominant, meaning that if you have one of these versions of this disease, you have an almost certain probability of coming down with it at one time or another. There's no known cure. And what causes it is a loss of a certain set of neurons in the basal ganglia. Now, just to jump to the chase scene, another disease that also has this is Parkinson's disease. And you kind of see them as mirror inverses or inverts of one another. And we'll talk about that as we get to it. Again, in Huntington's, you have a profound degeneration of the basal ganglia. And I want you to look, ladies and gentlemen, see where the basal ganglia is located. It is right in the middle of the brain. And it is right there adjacent to those rising and falling motor tracts and sensory tracts. So the amount of information that comes in here really makes this a very, very important region of the brain. Now, you will see in the basal ganglia a depletion of GABA, which is one of our neurotransmitters. Now, in the disease of Parkinson's disease, you're going to see, which also occurs in the basal ganglia, you're going to see a depletion of dopamine. Okay, so bear that in mind. But in Huntington's, you're going to see an excess of dopamine. That's why I said they're kind of inverts of one another. So if you ever saw that on a test, Huntington's, what is it characterized by? Too much dopamine, too little GABA. What is Parkinson's caused by? Too little dopamine, and too much ACH. Okay, now, and before we get any further into some of these diseases, ladies and gentlemen, I want to show you something that really worked for me when I was in your shoes studying the nervous system. And that is, I found it a little bit difficult to understand each one of the peculiarities of each one of these diseases. So what I did is I put them on a spreadsheet, and you can see that across the top here we have myasthenia gravis, Guillain-Barré, Parkinson's, Lou Gehrig's disease, or amyotrophic lateral sclerosis, Huntington's disease, multiple sclerosis, and Alzheimer's. And in the rows across, I put the onset, what are the early signs and symptoms, what are the major signs and symptoms, and so forth. And this helped me at a glance on one page. I had every one of these diseases. Now, a couple of things I just want to point out to you. If the patient comes in and they are complaining that they had a very rapid onset, that, you know, just a few days ago I was feeling good and now all of a sudden I'm feeling very lousy, the two most rapid diseases are GBS or Guillain-Barré and ALS, or the amyotrophic lateral sclerosis. Now, those two can come on very quickly. The remainders of these are very slow, or are slower. Now, the other clue is whether or not the initial sign and symptoms occur centrally, that is about the face and about the upper thorax, or do they occur out in the periphery or distally. So we say if they occur proximally or centrally, that's one thing. If they occur out in the lower limbs or out in the hands, this would be distal or far away. Now there's only 3 diseases that occur distally: GBS, ALS, and Parkinson's. So as far as the rapidity of onset and the location of onset, 2 of them are exactly the same, GBS and ALS. They both occur distally and they occur fast. Parkinson's occurs distally, but it's slow. And all the others are central and slow. So make yourself a little spreadsheet like this, and I think you'll really find it works great for you. Okay, let's go to the next slide here. Now, what is some of the characteristics of Huntington's disease? We have this chorea, which is kind of an irregular, it's been called dance-like or ballet-like movements. It's twisting and writhing. And also, the thing about Huntington's disease is it's a very total destruction of the brain. It involves the thinking, the memory. It involves the movements. It involves changes in personality. Now, contrast that with, let's take something, ALS, Lou Gehrig's disease, for example. The patient doesn't move around at all. They become rather sort of frozen, but they do not lose their memory. Their memory remains very good, and their thinking remains very clear. Now, one of the smartest guys in the world is the professor. I'm forgetting his name right now, but a very brilliant guy. He's a professor over in England. It'll occur to me in a moment. He wrote the book A Brief History of Time, Stephen Hawking. Now, you don't get more brilliant than that, and yet he hasn't had Huntington's. He's had ALS for decades now, and so he's lost the the use of his arms and legs, but he still has his basic personality intact and there's no dementia whatsoever. Contrast that with Huntington's, where everything goes. Okay, a little bit more about Huntington's. When I grow up, my mind and body will slowly deteriorate until I choke to death. It's a very, very bad outcome. There's no cure. It's irreversible. And so we basically treat this with symptom management, keeping the patient comfortable. A little bit here on Parkinson's. This is and I'll start out here. It's, again, a degeneration in the basal ganglia, but it affects different neurons. Where the Huntington's disease affected neurons of ACH and GABA, the Parkinson's affects neurons of dopamine. So that you get dopamine begins to fall, whereas the other companion transmitter, acetylcholine, because dopamine goes down, acetylcholine just by comparison is relatively high. Even though maybe its level didn't go up, relative to dopamine it went up quite a lot. Okay, very important for you to remember that driver. And let's go back here. Parkinson's. So in Parkinson's disease, you can have what's called secondary Parkinsonism, which is usually it's caused by some known cause, such as a trauma, infection, drugs, or toxins. Whereas primary Parkinson's kind of occurs vaguely, without an identifiable cause. And it is the leading cause of neurological disease in people over 60 years. And there are several very important symptoms of it. Now, notice that early, the symptoms are subtle and they're gradual, and that's your clue. Again, you go back to your spreadsheet on Parkinson's. It is slow. Okay, very important to remember. So if you get a question on the test that says so-and-so has had vague symptoms developing, well, the Parkinson's might be one of those. Or it might be myasthenia gravis, or it might be Huntington's, or multiple sclerosis. All those are kind of slow onset. But there will be other information that will help you divide amongst those candidates and arrive at Parkinson's. Okay? Now, there are classic signs of Parkinson's, and there used to be three: rigid, tremoring, and bradykinesia, or moving slowly. So the patient moves very slowly, they're shaky, and they're very stiff. Those are classic signs of Parkinson's disease. Now, Parkinson, again, other things that can happen: you can have a change in emotional status. You have a change in ability to swallow. You can begin drooling. Urinary retention and constipation can be a problem. And your sleep can, of course, be obviously impacted by this. Now, Parkinson's disease, again, how do we treat this? Well, we diagnose it based on a history and then a physical exam. There's no way to manage it with certainty. So what we do is really try to provide symptom relief. Okay? Now, this is a spreadsheet that you could study to kind of familiarize yourself with these diseases. What is the cause? Well, over here we know that there's a genetic cause. The clinical manifestations are the chorea, and then the general brain degeneration. The treatment, we know the best ones there. Parkinson's, again, same story. You will see similarities and differences, and you got to learn the two so you will be able to choose which one it is on your test. Now, I'm going to go to the second PowerPoint here in just a second, ladies and gentlemen. I'm going to recheck our screen here to make sure everything is going fine, and it looks like it is. So we will continue with the second PowerPoint. Just keep right on going. There we go. Okay. We're going to continue with the part 2. And we're going to be getting into brain trauma and those type of issues. And I will be right back with you. Okay. Brain trauma. It produces, it's a traumatic insult to the brain. In some way the brain is impacted. It's a physical impact. It's not a metabolic impact or an electrical impact or some change due to a drug. It is a direct injury, physical injury. Now, some patients that are particularly vulnerable for this, young children, because they just simply don't know better, and they don't have a lot of coordination and control, and they don't have a lot of experience as to what's risky and what isn't. Now, adolescents, 15 to 19 years, because adolescents are known as risk takers. So by nature, when they start doing high-risk activity, they can, again, run risk of brain injury. Some of the things that can happen: a motor vehicle accident, falls, injury in sports, violence, and so forth. We do have improved survival outcomes. We've learned a lot in terms of the health care for persons suffering brain trauma. A difference here, categories. There are a lot of different categories of trauma. One is where it's closed, where the skull remains largely closed, versus open, where something has actually gone into right through and broken the skull and the dura, such as a bullet or a club or a knife, etc. Okay, but in the closed injury, the dura is generally speaking intact, and the brain tissue is not directly exposed to the environment. Mechanisms that can produce brain damage: primary, which is an injury by impact; secondary, which is a secondary result. In other words, this was not the primary thing. It was a secondary thing that followed it. Tertiary is something that happens much later down the line. Now, primary brain injury. This is a situation where the injury to the brain is the primary main event. And one of the things you're going to see, you're going to be able to see the injury one way or the other, or you're going to be able to see the results of the injury, the swelling, the fracture in the skull, and so forth. Now,